All right. So picking back up, last portion of our chapter 37 Airway Lecture. So we're going to be talking about ensuring adequate humidification. So tracheal tubes provide that artificial airway for gas to go to the lungs, but they don't function the way natural airways do, meaning that they're not going to provide humidification, the filtration that our upper airways do, the heating functions of our upper airways. So if I don't compensate by providing that heating and humidification to the patient, that's going to cause secretions to kind of thicken. It also can cause a decrease in that ciliary function, which is important for mucus clearance and that mucociliary transport system to work. And that's supposed to keep our lungs nice and healthy and clear. Okay. So the types of devices that we pick for humidification kind of depends on the patient's needs. Okay, so they talk a lot more about humidification in chapter 39, which you've already covered in therapeutics, but we typically use something called like a heated humidification system, where we're heating it, we're adding humidification. So this is going to get you as close to 100% humidification delivered to the patient as possible. So this is going to be most closely mimicking what we do what our body's supposed to do for us. We can also use heat moisture exchangers or HMEs. So typically these are only used in the short term because they're not as effective as these heaters. So if you're just going to be intubated for a very short period of time, you might choose an HME. But if there's any presence of like really thick secretions or a really high minute ventilation with your patient, or long-term use of an artificial airway, you would choose the heated humidification setup. Okay. So for minimizing nosocomial infections, this is another responsibility for us as respiratory therapists. So patients that have these tracheal airways in place are very susceptible to infections in that lower respiratory tract. So you're going to be looking for things like changes in their secretions, color, consistency, amount. So typically if, their secretions had been clear or white and they now look yellow, green, creamy, pussy, that can be a sign of infection. I'm also going to be looking at my patient's breath sounds. Wheezes can indicate an obstruction to the airway, so it could be from inflammation or secretions in the airway and a sign of infection. Crackles are associated with consolidations, so it can be inside of an infection, or rhonchi, meaning large amounts of secretions in the main airways. We can do chest x-rays to look for any infiltrates or areas of atelectasis that can be a sign of infection, consolidation. And then other things that the patient might present with would be like a fever, an increase in that heart rate, or leukocytosis, which is that elevated white blood cell count. Okay. So there's a box on the top of page 775 that talks about why tracheal airways increase incidence of pulmonary infection. This would be something that it would probably behoove you to kind of have a good understanding of for your exam. Okay. So how do we guard against infections? So first thing, we need to make sure that we're avoiding introducing organisms to airway. So we don't want to introduce things to the patient's airway that can cause an infection. So this is why we teach sterile technique with suctioning. You also want to ensure that the equipment that we're using for each patient has been cleaned and sterilized per protocol. Okay, so I want to make sure that I'm always using clean equipment with my patient to reduce the amount of transferring organisms through that indirect contact. Consistently performing hand hygiene between patients. So remember, we're the main transmitter of disease in the hospital is us and not washing our hands well. So you want to make sure you're washing your hands well before entering a room. You always, always, always 100% of the time need to wash your hands, put on gloves before entering the room. Take your gloves off, wash your hands again before exiting the patient's room. You also want to do that in between clean and dirty procedures. If I'm touching some bodily fluid, I am going to take those gloves off, wash my hands again before doing the next thing with my patient, okay? I want to also look at prevent retention of secretion. So I'm going to be doing things like suctioning our patients. Closed suction systems are always best. Another way I'm going to try to prevent the retention of secretions is by doing things like providing adequate humidification to my patients, performing appropriate chest physiotherapy with my patient, and performing good trach care. So if I have a tracheostomy tube, I want to make sure I'm cleaning it regularly. I'm changing out the inner cannula to minimize any bacterial contamination and infections. There's also some other techniques that that we use to kind of prophylactically prevent pharyngeal aspirates. So we do this by giving medication to our patients prophylactically to like reduce stress ulcers. Patients are intubated on the ventilator. They're very susceptible. They're not eating. They're very susceptible to stress ulcers or aspiration reflux. So we want to maintain normal gastric pHs by giving them like the sucralfate. That's a medication that kind of maintains that gastric pH, prevents gastric ulcers. We also do this by positioning our patient with a head of the bed at 30 degrees or higher. That helps reduce the amount of reflux a patient can have. And I want to continuously aspirate the subglottic secretions using those high-low vac ET. Okay. So providing good cuff care, we've talked, as previously mentioned, we talked about the fact that, tracheal stenosis, tracheal malaise are associated with improper cuff use. So it happens around the ET tube cuff or the tracheal tube cuff. So usually this is going to be related to the amount of cuff pressure that's in that cuff and how much of that transmits to the tracheal tissue that's surrounding it. Okay, so the cuff pressure exceeds the pressure in the tissue around it, that's going to cause ischemia, ulceration, narcosis, and other issues. So you usually want those pressures between 20 and 30. That should say centimeters of water pressure. And if you use so we talked about that high pressures cut off that blood flow, but low pressures are going to increase that risk of aspiration and infection. Okay. So, so like I said, the cuff inflation needs to be somewhere between 20 and 30 millimeters of mercury to prevent that mucosal injury. They also have kind of different types of cuff designs out there that can help minimize mucosal damage. So one of those is a phone cuff. This is designed to seal that trachea using atmospheric pressure. So I'm not inflating that cuff with any air. It's just using the atmospheric pressure to kind of seal off that airway. It's not commonly used in patients except for patients who have a developing tracheal injury. Then they'll switch to these phone cuffs. Tight to shaft cuffs are very low volume, high pressure cuffs. So these cuffs use a lot of cuff pressure, but there's not a lot of volume that goes into it that maximizes the airflow around the cuff when it can be deflated. So these are typically inflated with sterile water only. because that silicone material that it's made out of is kind of porous, so that won't, if you don't use water, your cuff will continuously leak. And then finally, they talk about the longer length, ultra thin polyurethane cups. The cuffs, these prevent silent aspiration by preventing the formation of channels. So when you look at the ET2 cuff, you can see how, if you're not, how when it's semi-inflated, it can kind of create folds and creases, and that can make channels for secretions to kind of slide down around in. But these longer length, ultra thin polyurethane cuffs kind of create a more smooth seal in the airway. There won't be those channels for those micro aspirations. So your book talks about minimizing the likelihood of aspiration, and it mentions swallow testing. So swallow testing is something that we do. Typically, this is done with speech therapy to see if all the food that the patient's trying to swallow is going into their stomach and none of it's going down into their trachea. Patients can experience something called silent aspirations, meaning that typically if you're aspirating, you're going to be coughing and hacking a lot. But if you're silently aspirating, it's just kind of slipping into that trachea unnoticed. So there's two types of tests that you can do. One of them is called a simple swallow test, where they add kind of blue food coloring to the patient's feeding. Then we're going to suction the patient, and if anything comes back blue in color, that means it's a positive test and the patient's aspirating some of their food. The other one is a little bit more complex test. It's called the barium swallow test. That's where the patient goes down to radiology typically. They go under fluoroscopy, and which is kind of like a continuous chest x-ray type thing going on. And the speech therapist will have them swallow like contrast, and they can watch as they're swallowing that contrast where that contrast is going. Okay. Everybody's favorite part of like having trach patients is trach care. This is one of those not it scenarios in a lot of hospitals of whether nursing or respiratory therapy has to do this. So I think it always behooves you, even if it's not an assigned task to respiratory therapy at your hospital, it's still a good thing that you're very comfortable doing this, because I will say at some of the hospitals I've worked at, even if it was nurses' job to do it, they had to do it so few and far in between, they were never comfortable, and we got tagged in a lot to help, which is appropriate. You want to make sure that trach care is being done effectively. If you don't have a lot of experience with trach care, it can be a little intimidating, but the more you do it, the more comfortable you're going to be with it. So when you're doing trach care, you're going to follow some simple steps. Always, you're going to be assembling and checking your equipment. So there's a box on page 778 that kind of gives you the equipment that you need to do for trach care. Most of the time these patients are going to be alert, and even if they're not, you always really want to make sure you're explaining the procedure to the patient. You start off by suctioning the patient because you want to clean them out before you start cleaning out their trach. So you're going to suction the patient. Then I remove and clean the inner cannula. So some inner cannulas you clean, some you just throw away in your place. After I've done that, I'm going to clean and examine the stoma site, so that incision site, to make sure everything looks free of infection or any redness or irritation. Then I will change the ties and holders, put in a new or a clean inner cannula. And then I will reassess a patient. So by that point, sometimes the patient needs to be suctioned again, but I reassess my patient for the need for additional suctioning. Okay. So we're going to do this in lab together, and you're going to get practice with that, and you have a competency related to that. But those are just kind of the basic steps of tracheostomy care. Okay. So trach care really needs to be cleaned at least daily, is what most recommendations are. If it's a newer trach, you might have your policy might to do it more frequently, like every shift, but at least once a day your trach should be cleaned. So changing out the tracheostomy tube, you always want to make sure you have an extra trach tube, the same size and one smaller at the bedside, just in case something happens and you need to change it out emergently. This trach changes can again need to be done emergently if like it becomes misplaced or it becomes plugged with the mucus plug, or something damages the cuff, or if a different size trach is needed. So respiratory therapists usually are the people who are replacing these tubes, these trach tubes, once the stoma is healed. So usually about 7 to 10 days after they had the tracheostomy placed, we're the ones that are changing out these tubes. Again, it's a very simple, straightforward procedure. Scares the bejesus out of you when you first, makes you nervous, makes you a little scared the first couple times you have to do it, but after you've done a few, you get pretty comfortable with it. So when you're changing out a tracheostomy tube, there is again, you're going to be gathering kind of your equipment. You need a new tube plus one size smaller, some water soluble lubricant. Again, you're explaining the procedure to the patient, you're preparing your equipment, so you're checking your cuff, making sure it works properly, making sure you have everything that you need. So typically when I prepare my patient, I want my patient to extend their neck. So that means tip their head back so their neck is wide open and accessible to me. I'm going to suction them. I'm going to hyperoxygenate. I will remove the old tube, then insert the new tube, confirm that it's in the right place by reassessing my patient, secure the tube, and then reassess the patient again. So that's pretty typical procedure. Again, you're going to practice this in lab. Okay. So kind of another big portion of being a respiratory therapist and dealing with artificial airways is being able to troubleshoot or identify airway emergencies quickly. So some clinical signs that you're going to see with patients are going to be varying degrees of respiratory distress. So like I said, when you have that what we talked about in the first lecture with obstruction, depending on how obstructed their airway is, they're going to be in respiratory distress, and it could be very severe. You're going to have changes in breath sounds. So wheezing, bronchi, stridor, all of those could indicate absent or diminished breath sounds. All those could indicate an airway emergency. Air movement through the mouth, or if the patient's like on the mechanical ventilator, changes in pressure on the mechanical ventilator could all indicate there's an airway emergency going on. Okay. Okay, so some of the so if you identify a respiratory emergency, you might need to replace the airway, provide manual ventilation. So supplies that are going to be necessary for that should be kept near at hand at the bedside when you ever have an artificial airway in place. One of the big things is those resuscitation bags with an appropriate size mask for your patient should always be at the bedside if your patient has an artificial airway in. Suctioning should always be set up in the room if your patient has an artificial airway in place. Tracheostomy tubes of the same size and a size smaller should be on hand. And then, if your patient's intubated, intubation supplies should be readily accessible as well. So if your airway emergency is a tube obstruction, these can happen when a patient is kinking the tube by biting on the tube. It can happen when you have a herniation of the cuff over the tip of the tube. It can be caused by an obstruction of the tube against the tracheal wall or mucus plugging. So any of those things can occur. So depending on which one of those things are, the treatment's going to be different. So if the patient's kinking or biting the tube, you're going to, reverse the obstruction by, repositioning the patient so that it's not kinked, or by putting like a bite block or an oral airway in to prevent the patient from biting on it. If there's a herniation of the cuff over the tip of the tube, This is where the cuff kind of slides down the ET tube and ends up covering the bottom of it. You need to deflate the cuff, and then you can try to pass a suction catheter through the tube to see if you can move it out of the way and then reinflate the cuff. The same thing if the obstruction's against the tracheal wall, you can try deflating the cuff, like moving the tube a little bit, and that should relieve the obstruction. Mucus plugs. If the suction tube is if a mucus plugs at the end of the ET tube, you can try to suction it out. If it's too thick or too solid and you can't clear it, sometimes you have to pull the entire tube and reintubate the patient if you've completely occluded your airway with a mucus plug. Okay, so here's just some examples of this. This is where there's kinked. This is an example of that herniation. This is where your ET tube is kind of obstructed because it is up against the tracheal wall. And finally, this is representing a mucus plug inside the tracheal tube, either an ET tube or a tracheostomy tube that's blocking the airway. Okay. Another common problem that might happen is a cuff leak. So if you have a leak in the cuff of the pilot balloon or that one-way valve, that is going to cause the patient to have a leak. That's going to mean that you won't be able to deliver the tidal volumes or the pressures you need to ventilate the patient properly. So if the pilot tube or valve is leaking, the tube needs to be changed as soon as possible. They do make repair kits, which I've never seen at the hospital, but an alternative to that is I've put like 3-way stopcocks on the end of my pilot balloons and, switched the top clock to the off position and sealed it off that way until I could replace the ET tube safely. If it's a ruptured cuff, that means that the cuff has burst. That happens sometimes where you check the cuff before you've intubated, it's held pressure, then you insert it, and the balloon busts. And now you're not going to be able to fix that, even temporarily. You're going to need to extubate the patient and reintubate the patient, or use one of those endotracheal tube exchangers that we talked about before. Okay. Unplanned extubations or accidental extubations. This is where your endotracheal tube gets displaced out of the airway. Usually this, we notice this because you'll have decreased breath sounds, or you'll feel air flow coming out of the patient's mouth around the ET tube, around the tube. That means that it's not, that airway is no longer sealed. Sometimes you'll pass that suction catheter and you're not gonna elicit a cough, and that means it's not in the right place. So if your patient becomes extubated accidentally, you need to completely remove the tube, provide some ventilatory support by that manual resuscitator and mask until the patient can either be reintubated or a new tracheostomy tube can be reinserted. Or you might assess the patient and be like, hey, maybe we'll try you off for a little bit and see if you do okay. Okay. So for like resuscitation, if you have if a patient's got a tracheostomy that has been displaced and I'm trying to manually ventilate that patient now without the tracheostomy tube, the best way to do that typically is to take a piece of gauze, cover the stoma area, occlude the stoma area, and then provide manual ventilation through the upper airway like you would do with a normal patient, one that doesn't have a surgical airway. Again, if you have a patient with a laryngectomy, which we covered in lecture 2, if it's a full laryngectomy, you need to provide that manual ventilation with a small size mask right over the stoma site, because there's no communication between the upper airway and the lower airway. With a partial laryngectomy, you can attempt both routes and see which one provides the better ventilation for the patient. Okay. Almost done, guys. Getting close to the end. So now we're going to talk about purposely removing endotracheal tubes, which the process is called extubation, or removing tracheostomy tube, which the process is called decannulation. Okay. So there are patients that, if you've got an endotracheal tube in, you are going to get extubated at some point. Either you're going to be extubated because you've successfully weaned from the ventilator vent support and you don't need the tube anymore. You're going to be terminally extubated if we've decided that further vent support isn't going to do you any good. So we're going to let you, you're going to take the tube out knowing you're going to pass. And then we have extubation that's done because we're going to be putting in a surgical permanent airway, like a tracheostomy tube, for long-term care. Tracheostomies also don't have to be permanent. Patients will get tracheostomies and overcome the kind of the reason for the tracheostomy in the first place, and then go through the process of what we call decannulation. Where we gradually reduce the size of the tracheostomy tube that we have in place until we've determined that they no longer need it, and then we pull it out and the surgical site eventually closes up. Permanent tracheostomies are, though, still common for patients. So if a patient's been surgically treated for a throat cancer or laryngeal cancer, or if the patient needs long-term ventilation support, those tracheostomies may become permanent, and we don't ever have plans of taking them out. So when we're assessing for readiness for extubation, we first off need to make sure that the original need for the artificial airway no longer exists. So if they got the artificial airway because they weren't ventilating and oxygenating well on their own, that has to have resolved itself. If we're doing it to protect the airway, we want to make sure that they're responsive enough and they've got the ability to protect their airway once we remove that tube, the ability to manage their own secretions, and that their upper airway is patent. Prior to extubation, we always want to do something called a cuff leak test. Okay, so as we mentioned with tracheal trauma, glottic edema, laryngeal swelling is common post-extubation. So in order to determine how bad that's going to be, a lot of times we'll do something called a leak test, which just means I'm going to deflate the cuff of that endotracheal tube, and I'm going to listen to make sure air will flow around it. If air is flowing around it freely and I sense a big leak, that means that my airway is open around my ET tube or my tracheostomy tube, and I can safely pull it out and have pretty strong confidence that my airway is going to stay open. If I deflate that cuff and very little or no air moves around that ET tube, that indicates that there's significant edema around my tube. And if I remove that tube, that airway could collapse further and cause an obstruction. Okay. So for the procedure for extubation, a lot of times you're kind of assembling the same type of equipment that you used for intubation. You're gonna get your suction ready. You're gonna have oxygen ready for the patient. You're gonna need a syringe to deflate the cuff. So you wanna make sure that you have equipment to reintubate the patient or put a new trach back in the patient if things don't go well and the patient needs that airway back in. Okay, so you want to have that equipment kind of assembled and checked. That also means that when you time your extubations appropriately, I always get frustrated when the doctors, the hospitalists, or the intensivists kind of drag their feet all day long, and then at 4:00 in the afternoon, they're like, let's extubate the patient. And it's like, great, nobody's here to put the tube back in if this doesn't go well. So maybe we wanted to do this earlier in the day when anesthesia was still in house. So that's always kind of frustrating. So you kind of want to plan these accordingly and make sure that the right people are available just in case you need to put the ET tube back in. So assembling the equipment, checking the equipment, making sure your suction's set up. Typically you want to suction down the ET tube, suction out the pharynx above the cuff before you want to extubate the patient. If the patient's due for any breathing treatments or anything like that, I always do that before I extubate. I just do everything I need to do with the patient while that tube is still in, suction the patient, make sure their airways are clear. I'm gonna hyperoxygenate the patient. And then I'm gonna deflate the cuff and remove the tube. So the key piece of this here is maximum abduction of the cord. So meaning I want to pull the tube out when I know the cords are going to be fullest open. So there's two kinds of schools of thought with this. Typically we used to, like always when we would do this procedure, tell the patient to take deep breath in and cough, and we'd pull this tube out while they were coughing. But as they're coughing, that actually can cause the vocal cords to kind of move to the center, which can cause a little bit of damage to the vocal cords as I'm pulling that tube out. So one of the other schools of thought recommendations is to tell the patient to take a deep breath in, and as they're breathing in, hold the tube out, because then those cords are moved furthest to the outside, furthest open that they're going to be, preventing any damage to those cords as you pull the tube out. Okay, so there's kind of two schools of thought, but you remember you want to, take a deep breath in and I'm pulling the tube out while they're breathing in is usually how I do it, or I switch to that method. Okay, so you want to apply oxygen and humidification and support the patient after the tube is out. Assess or reassess the patient after extubation. Okay, some common complications post-extubation. Most common problems are going to be that hoarseness, sore throat, cough. Laryngospasms are fairly rare, but it's still a serious complication. So with laryngospasm, you are going to want to give them oxygen to maintain a high FiO2 level. You might want to apply positive pressure with like BiPAP or non-invasive therapies. If it keeps going on, you may need to do a neuromuscular blocking agent and then re-intubate the patient, unfortunately. Again, remembering that vocal cord dysfunction is a complication because they're not being really moved while they're intubated. So after you get them extubated, those vocal cords might not want to close fully. So you want to be very careful to avoid aspiration in those first 24 hours. So like minimize the amount of food you're giving them, liquids you're giving them right after extubation. So they may aspirate even if they seem to have an intact gag. It's a good rule of thumb. I rarely see patients truly be NPO for 24 hours after extubation, but you just want to kind of closely watch them. Extubation failures is defined as a need to re-put that airway back in. So it's typically because of any type of airway problems. So if it's within 8 hours, it's considered extubation failure. Usually aspiration or edema are the most common reasons that the patient needs to be reintubated, or just because they decide that they need for ventilation, that they can't ventilate well on their own, and they need that support of their ventilation from the mechanical ventilator. Okay, so decannulation then is a term we use when we're removing the tracheostomy tube. So a weaning process may be necessary for patients who have had these trachs for a long term and have been on mechanical ventilators for a long period of time. So those patients typically experience some respiratory muscle weakness, just like if I hadn't been exercising for a long period of time and then I went out to try to go for a run, I'd probably not do very well. Just same thing with our patients with their respiratory muscles. If we've been doing the work of breathing for them, they now have to assume that work of breathing themselves, so their muscles might be a little weak. Again, the tracheostomy tube greatly reduces our anatomic dead space. So if I take that trach away. Now they have all this anatomic dead space that they need to fill up with volume. They're going to need to generate much higher pressures. And then typically upper airway secretions or upper airway problems and glottic closure from like those vocal cord disuse can cause difficulty with this weaning process. Okay. So kind of before we decide to take the tube out, we want to do an assessment of the patient. Typically, we want to look to make sure that they have a sufficient respiratory muscle strength. So we're looking for a peak expiratory pressure somewhere above 40. This tells me that you have enough force behind your cough activity. I want to make sure that my patient doesn't have any active infections or a lot of secretions that we're going to have to manage. A lot of times we'll check the upper airway for patency with a bronchoscopy and make sure that the patient can swallow adequately before we want to decannulate them. Okay, fenestrated tracheostomy tubes. These are those tubes that have, usually have an inner cannula and outer cannula. The outer cannula has an opening above the cuff to allow that airflow. So when I remove that inner cannula, that usually opens up that fenestration, allows air to go through that upper airway. So that starts convert patients over to more typical normal breathing. I can also use a cap, trach cap or speaking valve to block that trach and assess the upper airway and how well it's functioning. But if I'm going to do that, remember I need to really make sure I'm deflating that cuff. If I'm doing this capping or if I'm using a cap or speaking valve, those are kind of nice because it still maintains that tracheostomy tube. So if I need to suction the patient, I can take the cap off and just go in and suction the patient. I can still hook them back up to the mechanical ventilator as needed. I would just, if I'm doing that, make sure I put the inner cannula back in to close off that fenestration and reinflate the cuff. So one problem with this type of ET tube typically is that malpositioning of the fenestration, so that hole isn't in the right spot. So if it's in the wrong spot, if it's up against the posterior wall of the pharynx, this can cause an occlusion to that, so that fenestration isn't going to work. So I need to confirm the placement with it. You typically with like a fiber optic or a flexible bronchoscopy tube, they'll go down, look to make sure that that fenestration's in the right spot. So that we can use that to help us get the trach fully removed. So these fenestrated trach tubes are a great adjunct in trying to get the patient weaned off the trach. Another way of doing that is with a progressive smaller tube. So again, this maintains the airway, but it allows for increased use of that upper airway. So a lot of times this is used for patients that are too small for fenestration tubes. So peds, neonates. This also helps with improved stoma healing because as I'm going to a smaller size tube, that opening gets smaller and smaller so that stoma starts healing quicker. But with these smaller tubes, I'm going to be increasing my airway resistance. It's going to be harder for my patient to cough. This also, because of the smaller tube, might be putting pressure on certain parts of the tracheal wall that it wasn't before, and that can cause some ulceration and complications as well. These are kind of fun. You don't see these very often. These are called tracheal buttons, which is just, I'm taking the tracheostomy tube out and I put this little button in place to just hold that stoma open. So this button just sits inside the stoma and acts as a kind of a placeholder just to hold that tracheal wall open. It's not going to because it's not going inside the trachea, it's not going to increase airway resistance in the trachea. There's no cuff in there. So it doesn't, the benefit of it is allowing me still access to the trachea, so I can like use it to suction into the trachea, remove secretions, but it's not going to be like a true airway that I can put the patient on the ventilator or something like that. I've never actually seen a patient with one of these in. So those are kind of different, devices that we can use to progressively wean the patient off of that artificial tracheostomy tube and get it removed and facilitate decannulation. So after decannulation, you always want to reassess the patients. You're assessing a patient for vocal cord response. So a lot of times they can do that with fiber optic flexible bronchoscopy again, where they're looking down in there, making sure the vocal cords are moving properly. If vocal cords are dysfunctional, again, that can result in aspirations or airway obstruction. Some symptoms of that vocal cord dysfunction are going to be stridor because of the obstruction, increased work of breathing, which will result in retractions, or depending on how those vocal cords, if those vocal cords are paralyzed in the near closed or closed position, I won't be able to have any airflow through that upper airway. That all indicates that upper airway obstruction. So if any of that's present, you'd want to replace the tracheostomy tube, and you'd want to have suction equipment available so that you can put that trach back in quickly and safely and reestablish a patent airway. Okay, so that is the end of your lectures for chapter 37. Again, a lot of this information is supported and covered more in, especially the procedural parts, in lab, as you can practice those hands-on skills. Remember to be reading through your RCCs and watching those videos as well to help support, especially a lot of these procedures. There's a lot of procedures related to this chapter and competencies. So if you have any questions, please let me know.